Thanks for the introduction, Dr. Evans, and thanks everyone for joining. It's a pleasure to have myself and Dr. Pilch to give this talk on social determinants of health and transplant adherence in transplant patients. Next slide, please. Here are disclosures. I received research grant from Merck and served as a consultant to Veloxis Pharmaceuticals, and all other presenters and organizers of this content have no conflict of interest to disclose. Next slide, please. So briefly, our objectives for this presentation is to identify social determinants of health, inequities that contribute to non-adherence and affect transplant outcomes, explain the impact of medication non-adherence on outcomes post-transplant, and propose some strategies to help improve adherence and promote health equity, and discuss ways to assess health literacy. I'll focus primarily initially on the social determinants of health, and then Nicole will then focus on medication adherence and some proposals on ways to improve medication adherence and health literacy. So the United States Department of Health defines social determinants of health as conditions in the environments where people are born, where they live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. They break down these social determinants of health into 5 categories, which include economic stability, education and access to quality, healthcare access and quality, neighborhood and built environment, and social and community context. As transplant clinicians, it's important for us to understand the relationship between social determinants of health and how these characteristics or conditions impact patients, both transplant candidates and transplant recipients, specifically as it pertains to outcomes on transplant wait list and post-transplant outcomes, and how strategies to help mitigate some of these conditions to help improve outcomes after transplant. Next slide, please. So what are some examples of social determinants of health? Again, looking at it specifically from the 5 various domains. So as it pertains to education and education access and quality, what are the rates of high school graduation and enrollment in higher education within our patient population? Language barriers and degree of health literacy in our patient population, access to childhood education and early childhood education and development. From an economic stability standpoint, poverty, rates of unemployment, food insecurity and housing instability, access to healthcare, access to primary care, again, health literacy, insurance status. And it's not just about having insurance, but it's also about the type of insurance that patients have. And we'll talk a little bit about that, how that impacts outcomes in our transplant patients later on in this presentation. Access to healthy foods, quality of housing, the rates of crime and violence in environments where our patients reside, environmental conditions, and social cohesion, civic participation, discrimination, and rates of incarceration. How all of these different conditions or factors impact outcomes in our transplant patients. Next slide. So how the social determinants of health driven inequities impact medication access and adherence. So again, looking at it specifically from the various domains. So education, access, and quality. We may encounter patients that have poor health literacy, that have challenges with understanding complex medication regimens. I'm sure we encounter these types of patients on a daily basis. Economic instability, lack of insurance or inadequate insurance, and unemployment. And all of these factors often lead to high out-of-pocket costs or inability to afford medications or have limited access to important medications that our patients need after transplant. Healthcare access and quality, transportation barriers, patients that may not have the ability to show up to a clinic appointment because they don't have a right to show up to that clinic appointment, lack of primary care providers, limited or inadequate insurance, neighborhood and built environment, unsafe or unstable housing environments, food insecurities, and lack of telecommunications. Again, in this era of telecommunications, and telecommunications can also be a tool to help mitigate some of these social determinants of health, especially for patients that may have limited transportations. Virtual visits and things of that sort could be a way to mitigate some of these yeah, social determinants of health. But having access to some of these telecommunication tools like mobile phones or laptops or things of that sort, where patients can engage in these types of modalities, can also be challenging. Social and community context, low health literacy, lack of social support. We all know how crucial it is for patients to have adequate social support after transplant, and how that translates to improved outcome after transplant. Next slide. So this is data from the OPTN database, where they linked with the Nexus socioeconomic data and era deprivation index. And they looked at transplant candidates that were listed in 2022 and adult transplant recipients in 2022, and also living donors in that same year. The specific social determinants of health indicators that were analyzed included estimated individual annual income, neighborhood median household income, education level, health insurance type, and era deprivation index. Next slide. And when they looked at the outcomes of these patients, both transplant candidates and transplant recipients, what they found was waitlist mortality rates for kidney, liver, and heart transplant candidates were significantly higher for candidates that were insured by Medicare compared to candidates that had private insurance or those who had Medicaid. What I also found was lower estimated individual annual income and lower neighborhood median household income were associated with higher waitlist mortality rates for liver transplant candidates. And increasing neighborhood disadvantage as measured by era deprivation index was associated with increasing waitlist mortality for liver transplant candidates. Again, some of those factors that we talked about in the 5 domains of social determinants of health have a significant likelihood to have negatively impact outcomes in our transplant candidates and transplant recipients. Next slide, please. Again, in the same database study looking at the outcomes for transplant recipients, they found that higher income and education levels were linked to fewer deceased donor transplants for kidney and liver transplants. While what this essentially suggests is that patients who have higher income and education levels may have greater access to living donor transplants. And as we know, living donor transplants tend to have more favorable outcomes compared to deceased donor transplants. And greater neighborhood disadvantage was also linked to lower deceased donor transplant rates for heart transplant recipients, but higher rates for kidney transplant, liver transplant recipients, which again is an indication that these patients that have that live in greater disadvantaged areas may not have significant access to living donor transplant for kidney and liver transplant candidates. Next slide. In a registered SRTR database study, again looking at about 60,000 living donor recipients and living donors and transplant recipient pairs, and it looked at the impact of era deprivation index that was measured based off of zip code on the difference in social deprivation index between the donor recipient pairs, and they categorize these social deprivation indices into various quantiles. Next slide. Next slide, please. Well, I think we're having some technical issues, but again, consistent with the previous UNOS database study, this study also showed that African Americans and Hispanic transplant recipients have significantly worse outcomes compared to Asian and Caucasian transplant recipients. And patients who reside in more deprived areas have significantly worse outcomes compared to patients who reside in areas that have lower area deprivation indices. Are you able to? Thanks. So across all strata of deprivation, living donor transplant occurred across all strata of deprivation. And again, looking at specifically at racial disparities, Black and Hispanic to Hispanic pairs were significantly more likely to live in more disadvantaged areas compared to white donor recipient pairs. And recipients in anonymous or pair donation arrangements versus biological related types of donor recipient arrangements were more likely to reside in higher deprivation areas. So patients who essentially reside in higher deprivation areas were more likely to undergo paired exchange donation, but and also have anonymous donors compared to biological donors. And recipient characteristics that were found to be associated with high deprivation areas were hypertension as the cause for kidney failure, longer dialysis duration before transplant, and again, patients who have Medicare insurance, which is consistent with previous studies that I mentioned. Next slide, please. So what are the limitations for using social deprivation indices in transplant research? A lot of the studies that currently exist are small and they're in selective transplant population. There is a need for us to for more studies that assess the impact of social deprivation indices on outcomes in our transplant patients. So there's need for more studies in this area. Our transplant patients undergo psychosocial screening, and this process may also exclude high-risk patients, which can also potentially skew the existing data. And inconsistency across regions and studies is also a limiting factor for implementing SDI in transplant research. And possible over-reliance on ecological data using zip codes and area deprivation types of database types of analysis could also be a significant limitation. Next slide, please. So what are some strategies to help mitigate some of these social deprivation indices from a patient and community level? Having enhanced patient navigation and social support. Again, we all can attest to the benefits of having adequate social support for our transplant patients. So what does that look like? Assigning transplant social workers or navigators to patients that live in high social deprivation index areas to help them navigate the process of transplant evaluation, transplant listing, and post-transplant care. Connecting patients to community resources such as housing, transportation, and food access. From a financial or logistical support perspective, providing patients with assistance with transportation, lodging, medication costs, and during and after transplant. Some transplant programs may have specific funding to help patients offset costs, especially in periods where they may lose their insurance or may not have adequate insurance. Expanding funding for immunosuppression medications beyond standard Medicare limits. So I think the recent expansion in Medicare coverage for transplant patients through the Medicare Part BID program it's a very welcome development. But there is a need for broader expansions for patients with regards to access to immunosuppressive medications and other important medications after transplant. Community outreach and education. So providing culturally tailored education programs about living donation that will improve access to transplantation or provide more clarity about some of the misconceptions about transplantation. And healthcare engagement and in disadvantaged communities could be an important strategy. Engaging community leaders to help improve trust and awareness within the community is also a necessary strategy. Next slide, please. From a health system level perspective, using social determinants indices to help inform risk stratification. So incorporating SDI or area deprivation indices into risk prediction models to help tailor patient-centered and post-transplant follow-up. So, in developing algorithms for frequency of follow-up for patients or trying to tailor more patient-centered approach for our patients, utilizing tools like area deprivation index or social determinant indices to help provide a more tailored patient-centered patient care approach for our patients. Equitable access policies, implementing equity-focused policies in transplant center listing criteria and allocation algorithms, incentivizing transplant programs to engage in underrepresented high SDI populations through outreach programs, and again engaging with those community leaders. And utilization of telemedicine can also help mitigate some of these barriers, specifically in patients who may not have access to transplantation, who may live in rural or high deprivation areas. Next slide, please. From a policy and structural intervention standpoint, advocating for including social determinants of health, like the social determinants index, in national transplant allocation policies and performance metrics, collaborate with public health agencies to help improve neighborhood level resources like transplantations, access to primary care, and affordable housing, and continue to monitor and publicly report outcomes by social deprivation indices to identify gaps in access impacts of interventions. Again, there's a need for us to, perform more research studies or assess these types of social deprivation indices in clinical trials. So I think there's more data that's needed for us to further identify some of these gaps and provide data-driven solutions to some of these challenges. Next slide, please. And this slide is just providing some resources for social determinants of health. The County Health Rankings and Roadmaps is a great website to help evaluate state and local trends and access to care. The IPRESRD network is an annual report that helps with health statistics like vaccine status, dialysis vintage, and the United States Renal Data System is a comprehensive national database on kidney disease and end-stage disease. And certainly the Center for the CDC website is also a great website for national health statistics and trends. So that will conclude this portion of the presentation as it pertains to social determinants of health. And I'll transition to Nicole to discuss medication adherence and tools to help improve medication adherence.
Thanks, Hydris. Well, it's a hard topic to follow, social determinants of health, that sort of 20,000-foot view of things, and switching over to kind of, getting to the bedside with our patients. And even though I'm not in patient care currently, I'm going to share a couple of patient stories, but I want to just get the group to sort of imagine. This is sort of a scenario that I encountered with a pharmacy resident where we had a patient, and they were emergently transplanted, and they were wondering why they weren't super excited about that transplant. So imagine you're whatever age person you are, and you have a recent diagnosis of dilated cardiomyopathy. You end up progressing, and your heart failure must be managed with an LVAD. Imagine in the olden days, an LVAD, and you're unable to finish your postgraduate pharmacy residency training secondary to your illness. You're worked up for a heart transplant when you're readmitted for a driveline infection, and then you're placed on the heart transplant list, and you end up receiving a heart transplant and develop post-transplant kidney failure. And despite it all, you're discharged to rehab 6 months later with a regimen of 12 medications and insulin because you developed post-transplant hyperglycemia. This story kind of always resonates with me because I think it's something that we forget with our patients, that, just like all of us have bad days, these patients have lots of bad days. And it's a huge, conundrum to deal with an end-stage disease and then have to undergo transplant. So just thinking about, this AI-generated gentleman, this was my AI-generated pharmacy student here. And can you imagine if you had to go through all that and derail all your plans? So again, you're finally discharged from rehab and a bit tired of your illness. And you feel like your team really doesn't understand and they want you to be excited that you got that transplant, but it's hard. So for the next several slides, we're going to do a couple of fun things. We're going to just redefine non adherence and health literacy, just so we're all on the same page, and then try to identify some of those variables associated with the variance in health literacy, because I think this is one of the struggles that at least I had in practice, is really trying to understand, giving instructions and making sure that the patient could follow the instructions, that the caregiver could follow the instructions versus adherence. And then talk about some specific populations in solid organ transplant that are prone to this sort of non adherence, and then look at some ways to improve it, maybe a call to action as well. And I'm going to throw in a party game as well that you can use during Thanksgiving. So be prepared. Okay, so why we don't like non-adherence, or why we don't like that non-adherence thing? Well, it wastes resources for our patients, for our healthcare system, potentially our time on the clinical side, leads to poor graft outcomes, readmission, graft loss. It helps contribute to our continued supply and demand issues if these patients have to be relisted. So we don't like non-adherence. But it's challenging, right? Because if you are a patient with multiple chronic conditions, it's challenging to keep that motivation up with managing those. If we can think about, a fourth of Americans are labeled as having multiple chronic conditions, and most commonly we see in our patient populations diabetes, constantly pre-transplant diabetes, post-transplant diabetes. There's tons of guidelines and research to support chronic conditions in transplant, but does it matter if the patient doesn't follow these recommendations, or we can't get them to follow them because they're too challenging? So we do a lot of work, I think, in the early post-transplant period, where I would suggest that adherence is improved because we have more continuity of care. We have more connection with the patient, especially in the early post-transplant period of time. But I would almost have a call to action to think about further post-transplant and really engaging those patients that are further out from transplant, because we know that adherence goes down over time. And so we know that there's 5 factors that impact adherence. And we've seen that on some of the most recent surveys of solid organ transplant population that we'll get to. But the healthcare team has a huge impact, and the engagement and trust that our patients have. Along with everything that I just talked about with socioeconomic status and condition related, what are the therapies, the complexity, and then just patient specific factors and access to care. So we know that non-adherence contributes to continued supply and demand challenges. That's a given. About 23 per 100 organ transplants per year yield some kind of non-adherence related acute rejection, chronic rejection, maybe infection or recurrent disease. And we know that this increases morbidity, mortality, and medical costs. So if we look at health literacy as a pivot point from non-adherence and kind of think about, well, are patients not adherent because they just don't have that health literacy to understand what we're asking them to do? Maybe that's where we need to focus on. So the CDC defines health literacy as the degree to which an individual has a capacity to obtain, communicate, or process and understand basic health information and services appropriate to make healthcare decisions. And this has to do with the ability to read, understand, and transmit medical information and adhere to medical advice and regimens. I don't know if anybody's been to the doctor lately, but Medicare is doing a new requirement to ask additional questions about how you receive healthcare information. And it was funny when I was at a clinic visit for just a well visit for myself, and I got all these questions asked to me, close ended. I had a hard time understanding, how do I want to receive what? So it was just interesting that those interactions. And of the US adults, on average, over a third of them are estimated to have low literacy versus only, just over 12% are proficient. And we know that there's a huge range within the US transplant recipient pool as well with health literacy. So most of the data, unfortunately, is in abdominal organs. So if we look at kidney transplant and low literacy rates, we can see a correlation with increased serum creatinine levels, right? So low literacy, you have higher serum creatinine levels, and that we know that chronic kidney disease is also associated with that. In liver transplant, you can also see that health literacy impacts outcomes as well. So improved health literacy reduces hospitalizations. So thinking about that focus on health literacy may be a way to go, because this is something that we can really help with and identify for patients. So who has low health literacy? Well, I think that's the big challenge is you really can't assume. There are some risk factors we know. The ones that have the asterisk are sort of the non-modifiable, but everything else is modifiable. So we've got increased age, minority race or ethnicity, but other things we can help with, potentially making sure that we have appropriate interpreters for non-English speaking patients. We know that, potentially patients who don't have appropriate or are undercovered for their insurance and have lack of access, vision, hearing impairment. All of those things need to be assessed and continually assessed because they change over time, and that may impact definitely adherence over the long period of time as well. So let's think about an example. And this is adapted from real life. I'm sure that everybody can come up with an example. And if you have one, as I'm reading this out, throw it in the chat. So imagine you're a pharmacist in a clinic and you're asked to see a patient who's 6 months out from transplant who's experiencing persistent hyperkalemia. The nephrologist comes over to you and says, geez, I cannot figure out why this patient, they have been on all of these meds forever. Why are they all of a sudden getting hyperkalemic? Can you look at all their medicines and just try to figure out? And, of course, I'm looking at it thinking, okay, well, it could be the Bactrim, it could be the lisinopril. Just offhand, maybe their prograph is super high, but it looks like their creatinine's doing okay. They don't have that kind of renal tubular acidosis, so probably not that. And so I review the patient's medication list and look at the patient's medication card. And I noticed a couple things. So the patient's caregiver is not currently in clinic and the patient doesn't know his meds, says my wife handles everything. Okay. You see this medication card that they have all scratched out and penciled and overwritten, and you see several medications kind of all over the place. And then you're like, okay, well, I can't do anything with this medication card right now. So we need to get a new one of those. But let me see your pill box. So we open the pill box. Whoa, there's some large yellow enteric coated tablets in there. Well, geez. Okay, so we lost something in translation here, and the patient is hyperkalemic because they're continuing to take potassium that they were probably prescribed, eons ago post transplant. So, barriers to medication adherence that I've heard, and again, share in the chat things that you've heard. I don't have a car to pick up that new prescription. I can't pay for that medication out of pocket today. Wait, I was supposed to change my dose? They just said hold the dose, and that will likely go down to 3 milligrams twice daily, but they never confirmed it, and I didn't really ask. So, we're kind of shooting ourselves in the foot and doing this to ourselves by not making sure that our patients are able to follow our instructions to adhere to what we're talking about. And then another one is my blood pressure is better at home. I don't need medicine. So that was another big one that I heard. Okay, well, then bring in your log. So all of these kind of disagreements, understanding issue, means, and access things that were talked about at the beginning of the talk, really, we could dive into those and help our patients access things. So, what can we do? So, we need to determine their level of knowledge, and we know it can change over time. So, I think that's the other big issue is, immediately post transplant, you may have somebody who's right on it, but now they're a few years out from transplant and they don't have that same motivation. Also, caregivers that were present early post transplant may not be present later. And then, English is a second language or non English speaking, especially if you have a caregiver who was supporting that patient that is English speaking and being able to translate information or cultural barriers, those things. So, we need to think about how to determine some interventions because we know that they can change over time. So, thinking about those open ended questions, the teach back model, everything that we learned in pharmacy school way back in the day, making sure our reading material is fourth grade or less, usually potentially using technology, smart bottles, blister packs. I saw a couple of those things coming out on the listserv this week to see if folks are doing those things to help with adherence as well. And then healthcare providers need training to recognize low health literacy. I think that's a big issue. And, I think pharmacists, just based on the workforce, are stretched pretty thin. And so it would behoove us to train not only pharmacists, but the rest of the healthcare team also to look at health literacy as well. So there's a couple of tools out there. Again, put in the chat if you've ever had other things that you've done at your center to improve adherence. So we've got the test of functional health literacy in adults. We've got the newest vital sign. The rapid assessment of health literacy. I left you some of the toolbox references here in the slide deck in case you want them, but we're going to play a little bit of a game with the newest vital sign. So if you haven't done this before, it's fun. So if you have done it before, maybe you don't read the answers. So just bear with me and think about it. Grab a piece of paper because you're going to need it, or at least I usually did when I was doing this. Um, this newest vital sign is kind of a Pfizer tool that was developed. It's based on an ice cream container. So you could potentially give this to your patients or use it at Thanksgiving dinner and give this to relatives and friends as a fun party game. So you're given a label and you're asking 6 questions about it. And from the toolkit, if you wanted to use this, basically here's the script that you could read to your patients. So we're asking our patients to help learn how well our patients can understand medical information that the doctor gives them. Would you be willing to help us by looking at some health information and then answering a few questions based on that information? Your answers are going to help our doctors learn how to provide medical information in ways that our patients will understand, and it should only take you 3 minutes. So, again, if you're going to do this at the Thanksgiving table, make sure you start your watch for 3 minutes. Okay, here's the label. So take a look at the label, peruse it. So I'm going to ask you these questions, and at the end, I'll go through the answers. But if you're willing, you can put your score in the chat or give me your reaction in the chat as well. So if you eat this entire container of ice cream based on this label, how many calories would you eat? Next question, if you're allowed to eat 60 grams of carbohydrates as a snack, how much ice cream could you have? Your doctor advises you to reduce the amount of saturated fat in your diet. You usually have about 42 grams of saturated fat each day, which includes 1 serving of ice cream. If you stop eating the ice cream, how many grams of saturated fat would you be consuming each day? If you usually eat about 2,500 calories in a day, what percentage of your daily value of calories will you be eating if you eat 1 serving of ice cream? And then pretend you're allergic to substances like penicillin, peanuts, latex, gloves, and bee stings. Can you have this ice cream? And finally, if depending on what your answer on number 5, why not? So that took me about a minute and a half to read. So I'm going to give you about 30 seconds to write down your values, and then we'll go through it. Math is hard for me, so I had to use a piece of paper. I'm going to be honest. Okay, 5 more seconds. All right, so here are our answers. So if you eat the entire container of ice cream, how many calories would you have? 4 servings times 250, 1,000 calories. If you're allowed to eat 60 grams of carbohydrates as a snack, how much ice cream can you have? And based on the serving size of a half cup, total carbohydrates are 30. So you could have anything up to 1 cup. So 2 servings of a half cup. Your doctor advises you to reduce the amount of saturated fat in your diet. You usually get 42 grams. If you stop eating ice cream, how many grams of saturated fat would you consume a day? And so we're saying that you subtract. And if you usually eat 2,500 calories a day, what percentage of your daily value of calories would you be eating if you had 1 serving? 10%. Is it safe for you to eat this ice cream? The answer is no. And it's because it has peanut oil. Come on, who's not going to do that at their Thanksgiving dinner table? That's fun. So if you score it out, patients who score a 0 to 1 suggests a very high likelihood of limited literacy. So they basically only got 0 or 1 questions correct. If you have 2 or 3 questions correct, that indicates a possibility of limited literacy. And then if you have 4 to 6 questions correct, it almost always indicates that you have adequate literacy. So this is just one example of a tool that you could potentially use to see about adherence and health literacy. And can you imagine, especially when patients with multiple comorbidities are getting multiple messages from the providers, that this could be challenging to interpret. So again, be that health literacy detective. Never assume higher literacy doesn't mean better understanding. So even those college professors who are coming in for a transplant after they're retired doesn't mean necessarily that they are able to communicate or understand the information that they're receiving. And just because somebody doesn't ask questions doesn't mean that they understand as well. Use that show and tell. Make sure you're checking those med boxes. I found all kinds of fun extra drugs in people's med boxes. over time, especially ones that were used pre and post transplant. And then careful of those disease state influences. And this is something to remind learners, patients who have encephalopathy or other comorbidities that could challenge their mentation, making sure that they have adequate support and understanding to move forward with health literacy. So, what do you look for? These are common things that we see in the literature or things that you can do at your own center to analyze data. So, looking at those blood concentrations and variability, have to know the PK to understand and looking at those trends over time. So, creatinine variability, tacrolimus variability, multiple papers out there showing correlations between those, asking those open ended questions, maybe doing some pill counts and refill history. And then looking for those signals. This is a great quality measure that we used to use is missed appointments and incomplete forms was a huge way that we could identify that patients were having a challenging time doing the follow-up. Sometimes it was our own fault. For example, we thought we had a huge issue with missed appointments but the problem is we had a scheduling issue where it rewrote all of the appointments. So we got a ton of cancellations versus clinic templates. So you also have to look at your own internal services as well and make sure that you're not causing the discrepancies that you're seeing in patients' records, that it wasn't, something in your system that looks like somebody is not adherent as well. So let's go back to another case. So why would you want to be non-adherent? That's always, again, a common question to get from learners. So think about this patient. AGA is a 19-year-old liver transplant recipient, secondary to end-stage liver disease from biliary atresia with a failed Kasai, who now recently went off to college to study engineering. He presents following winter holidays with right upper quadrant pain, some nausea and vomiting, not feeling great. And he's seen in the transplant clinic and is noted to have significantly elevated liver function tests. The patient's admitted for further workup. You can see the patient's regimen here, some tacrolimus, Pepcid, some Celicept, getting further out from transplant. And following the admission, you start that detective work and you're looking and you see, boy, we've missed a lot of labs in the fall, missed his appointment. But, mom says, nope, he's been filling it. I know it because I get the medicines to him. He's taking his medicines. But his last tacrolimus level on file is 8.6 in October of the previous fall. And now it's January. And the level is now 2 after a single dose given on the night before for the admission. So when you're looking at this patient, that's challenging with adolescent transitions. So if we look at adolescent transitions of care, that's the time when we need to do that increased monitoring and potentially having more scrutiny for our patients. Identifying these young patients who are at risk for these non-adherent behaviors and making sure you follow up with them. And knowing that their motivations to follow instructions are a bit different. They change over time. So when we looked at a survey of kidney patients in the clinic aged 18 to 25, it was identified that they have different things that they're concerned about. They're concerned about being in control. They're concerned about their appearance. They're more opinionated. They want to be independent, but they're pretty easygoing and pliable. So they're going to say yes, but maybe it's no. So making sure that we've got objective criteria to monitor them during these transitions could potentially be important. So, peers, not parents, play the role now, especially in these teen transitions. Again, their appearance and potentially having to adhere to a regimen can be challenging for them. They want to be adherent, but maybe there's things in their life that are making them challenged to be adherent. And they want more monitoring from the healthcare team to help them keep in line and prevent rejection. So that's something to think about, especially with those transition, is making sure that we have labs and follow-up visits and that we're targeting these specific patients during adolescent transitions so that we don't have rejection episodes. So going back to the patient, so following the admission, it was noted the patient missed his appointment in the fall in his labs. Again, mom says, nope, filling everything. But when you go in and talk to the patient, you find out, well, he's just been having a really hard time remembering his evening dose. Most night he's out studying or out with friends. And this has been going on for the last couple of months, that he just hasn't been able to do the evening dose and he didn't want to share it. It didn't seem important. He's very far out from transplant. So these are the kinds of scenarios that we need to keep in mind, is sort of anticipating when a patient potentially could have some roadblocks, either by nature or design. So handling these transitions, it's important to consider more frequent monitoring or potentially doing something that's longer acting, especially for these college students, maybe doing something like belatacept that we can monitor that the patient gets the infusion, or doing something that's a once a day regimen. Forget this twice a day stuff. Don't worry about that evening dose. figure out with the patient what works best for them and switch it to something that is feasible. Because again, we can give all the instructions we want and say that this is the ideal scenario, but if they're not going to do it, it doesn't matter. So we need clear and effective communication. I think we tend to overestimate our patients' health literacy. And sometimes that makes us feel inadequate. If our patient has low health literacy and they're just not able to get it, that that almost feels like a reflection on us, but you need to take that away and figure out how to work around it. And don't judge patients on that health literacy, but see if we can mark signals to get to their understanding or help, you know, break down those barriers for them as well. So, a couple of more recent publications. One in 2018 was kind of the first to what Dr. Tabor presented at ATC or WTC this last fall. But remembering back to this early meeting, this was the FDA public meeting on patient focused drug development and medication adherence in solid organ transplant. And during this discussion, that was a collaboration between physicians, pharmacists, patients, and nurses, nurse coordinators. It was found that transplant specific factors and medication non adherence um, you know, coincide. So, really looking at the factors that are sort of in white are things that we could potentially impact versus some of these socioeconomic and patient related issues that they're non modifiable. But we could potentially reduce the complexity in the medical regimen. We could potentially talk to patients and say, which one of these meds is bothering you the most? They don't understand it. Their pill box needs to be cleaned out. They need a better system. They have negative beliefs about the medication. Maybe they have untreated psychiatric disorders or depression. They have poor access, poor planning after an admission, and then poor communication. They don't want to ask the physician questions, and so they're not getting responses or answers to help overcome adherence and barriers. So keeping this in mind, we know that patients are asking us to stop making it one size fits all. They want to make the regimens easier. They want to have potentially mentors to help them through the post transplant process. They want us to bring down costs, and they want to make up follow up quality, not quantity. So, not sticking to having to get your labs and clinic follow ups at these certain time points potentially, but making sure that their follow up is tailored to their individual status. And then watch and help support psychosocial burnout and treatment issues. So, really having that empathy to ask those questions. And then we know that the most recent paper by Dr. Tabor and colleagues looked at the therapeutic needs of solid organ transplant recipients based on a recent survey of over 10,000 adults, or excuse me, over 10,000 patients, 95% of them adult, and had validated patient responses. And in those responses, the biggest things that were coming out of it was really that trust in the healthcare team, their fear of rejection, fear of cancer, along with all of these other quality of life things, really enticing us to start getting more patient specific and having these conversations to make sure that we get appropriate outcomes. So I'm going to hand it back over to Idris to kind of close us out with some additional questions. But hopefully you enjoyed the party game, and I hope to hear from you to see how it went if you're having a Thanksgiving dinner somewhere.
Thanks, Nicole. So wanted to gather what are some of best practices that you've incorporated in your center in identifying social determinants of health or potential barriers to medication adherence after transplant, and any interventions that you may have implemented at various centers. To please share them so we can discuss and share from those experiences. Please feel free to unmute your microphones, or you can drop some of those. You can just drop them in the chat as well.
I can kind of get us started here. Something that we did that I liked at my previous center from a health literacy standpoint, we actually had patients and our caregivers watch a video that provided like a general overview of standard medications after transplant. And they were required to watch that video before they met with us regarding their regimen. And that way they kind of had a baseline understanding of the meds prior to their education session with us. And we were able to get that video uploaded into the EMR. So it was something that they kind of always had access to, which was awesome. So they could always refer back to it if they needed to. And before we rolled that video out, we actually had to get it approved by like the system level health literacy committee and have them approve the language. So it was pretty interesting going through that process. And overall, we had a really good experience with that strategy, and patients tended to be a little bit better prepared to ask us questions and have just better understanding before they left the hospital regarding their meds. So that's something we rolled out at my previous center.
Thanks for sharing that, Ricky. I think that's a great tool. I think that, providing patients with those types of resources where they can always refer to those types of education is extremely important. I think that there were some patient adherence videos that were put together by the Transplant Pharmacy AST Transplant Pharmacy COP last year, that are also great tools, just very short videos that really discuss this, issues as it pertains to medication education and medication adherence are also great resources as well.
Anybody else want to experience anything you've tried at your center in the chat, or want to unmute your mic to kind of share your thoughts? All right, looks like we have a question here. All right. So a question from General Trophy Clark. We tried to use the newest vital sign in our post-transplant kidney clinic in the past as part of a clinical trial, but it found that it took patients a lot more than 3 minutes to complete, with many requiring up to 10 minutes. Has that been your experience as well? It's kind of been a limitation they've seen with their coordinators using it. You guys have any thoughts on that?
Yes, it does take a lot longer. And I think it was generated with a different level of health literacy for its initial the initial statistics. Although on the flip side, it could potentially be something that suggests that our patients have very low health literacy because of the time requirements if we were only to give it. So I think more information would be helpful, and maybe even a call for folks on this call to generate a newest vital sign specifically for transplant may be helpful with patient specific questions. That's one thing that we did when I was in practice, is we would ask a couple of questions. I had our nurse coordinators ask a couple of questions to see if folks were able to repeat back dose adjustments and laboratory follow-up, and then grade them on a kind of a psychosocial status. And we found that there was continued health literacy, and that the length of time that they were spending with patients was much longer. So we had to spread out and get additional resources for our clinic as well. So it could potentially be something where additional resources could be pulled in too. But Jennifer, you're absolutely right. I would love to see if we could develop something else similar to the newest vital sign that can be done quicker and more easily in our patients. But again, maybe it's a telltale sign of really where we are with health literacy in our patient population.
Yeah, excellent question. Another question we had from the audience, not an experience, but a question. Do the panelists or audience have any suggestions for identifying non-adherence and transplant recipients at a population health level to kind of stratify who would benefit from pharmacist engagement, and not just when identified on an individual basis? Any thoughts on that from the panel or anybody in the chat?
I think from a population perspective, I think some of the things that Nicole has really emphasized in her talk regarding some of the risk factors for medication non-adherence. I think one, I think there's a need for us to further explore this in research and further identify some of these risk factors. But I think from a population standpoint, as a program, identifying some of these patients that perhaps have some of these risk factors, and trying to tailor interventions specifically, not post-transplant, but prior to transplant, and have some interventions prior to transplant to help mitigate some of these risk factors, could significantly improve outcomes after transplant. I don't know if Nicole, if you wanted to add anything else.
Yeah, I was going to say that I'm not a paid spokesman for Dave Tabor or anything, but I'll just point out again that he's done a big VA study with multiple centers looking at tacrolimus variability and kind of mislabs, sort of those signals that we pointed out in the presentation that you could potentially look at in your own transplant center as putting some triggers in your Epic EMR about tasks that are not completed, that type of thing that may be triggers. That's another paper to look at. The benefit of his intervention was it was done in a VA system, so a little bit bit different because you're in sort of a closed healthcare system with a consistent medical record across multiple centers. But it'd be interesting to get a consortium of folks together to do this to see if any type of signal could pan out that could be used cross sectionally as well. So yeah, really good point. But again, I'll make sure Dave gives royalty to the PRN for all of the publicity here.
All right. There are a lot of discussions about this topic as well at WTC, and I think there's some movement with regards to the transplant recipient adherence and monitoring and management tool, or the TREM tool. I think there's potentially next phase of implementation of some of these tools in electronic medical records. So I think in the future we may have additional resources to help track some of these adherence factors in our transplant patients as well.
And I don't want to put Tiffany on the spot, but if she has anything to add from the TPAC committee, they have lots of great resources as well.
One comment, this is Tiffany. Hi, everybody. One comment in terms of kind of population surveillance. We presented this in our update at WTC, but Epic, we're working with Epic for the build of the immunosuppressive adherence screen. So the ITBS, or sorry, immunosuppressive therapy adherence screen, and then the barrier screen. It is going to be submitted in the November update. At the time of the meeting, we didn't really know what that meant. November updates, every center kind of does it different. So it will be later in 2026 when that comes out. In the next month or so, we're going to have some more information and try to do a webinar to show. But basically what that means is when your center, if you're an Epic using center, it's going to be standardized adherence assessments that you can pull in and use. They're quick. You can do them in person. You can send them to your patients ahead of time, things like that. But that may be a way to screen. So people that are not adherent then go to the barrier screen, and then they would identify specific barriers. And then you could potentially use that. So I know I'm giving you a lot of information now if people weren't at WTC, but the idea is to kind of give something standard instead of each center piecemealing, I do it this way, you do it this way, but we could all use the same thing. So stay tuned. We'll have more updates, but I think that could be a very nice, simplified way of a population assessment.
That's awesome.
Thanks, Tiffany.
Yeah, that's great insight. Another question, I think we have time. Another question we have from the audience. Has your center rolled out any initiatives to specifically increase access to transplant evaluation, as that can be a challenge for patients even prior to transplant?
Sorry, put the last part again, Ricky.
Yeah, so has your center rolled out any initiatives to specifically increase access to transplant evaluation, as that can also be a challenge for patients even before transplant?
Specifically in my center, some of the things that we've done is we've focused a lot of our efforts into outreach and trying to streamline our transplant evaluation processes by eliminating some of the additional steps. So if we can have patients come in and do as many of the tests and the evaluation process on a single day instead of having them come in for several visits, just trying to eliminate any redundancies and things of that sort in the evaluation process is something that we've explored at my center. But I think from a community outreach perspective, we've done a significant amount of work reaching out to the community and doing a lot of outreach programs, particularly in terms of trying to expand our living donor program and things of that sort is some of the approach that we've done at my center. But again, I'm open to anyone else who has any insights or comments on this.
Yeah, that concierge service and kind of getting all of those tests done. I think we're hopefully hearing our patients now and making sure that we can make them only have one visit. I know being on the coast at MUSC, and Ricky, you can probably speak to this better since I haven't been there in a while, but we did a lot of that coordination with cardiology to make sure that we could do kind of a pre-assessment of patients who would likely need additional testing, and then getting that scheduled on the evaluation day so that we can get more of that one-stop shop and get all of their labs and all that kind of stuff all within our system instead of having to pull together multiple records and really streamlining the evaluation process. I think it's really just convenience is the big thing for both patients and caregivers as they're coming through the process to make it as easy as possible. And then I think also opening the patient's eyes to multiple kinds of donors that they could accept, between hepatitis C or DCD or extended criteria donors, and really getting that education out to patients so that they have more of a selection to be listed for and a better chance of getting an organ on the wait list is maybe another suggestion as well.
Excellent insight. Any last minute questions from our audience? I think we have one more. No, I think that's it. Well, thank you to Dr. Jakubo and Dr. Pilch for sharing their expertise and insight today. And thank you all for joining. Have a good holiday, everybody.
Thanks.